In the name of the Father, of the Son, and the Holy Spirit. Amen. My beloved sons, today's topic is chronic heart failure. So let's clarify the questions that were confused you during previous board exams. And we start, okay? Yes. Let's begin. So chronic heart failure is a pervasive and complex clinical symptoms resulting from almost all structural functional cardiac disorder that impairs the ability of the ventricle or the ventricles to fill with or eject blood, systolic and diastolic dysfunction. So, my beloveds, mastering its multifaceted nature is fundamental for every doctor, no medical student, and practicing doctor, of course. So, chronic heart failure often develops insidiously, progressing through distinct stages. So A, B, C, D, according to American College of Cardiology, ACC, and AHA, American Heart Association, over years or even decades. It rarely appears overnight without preceding cardiac insults. So what is clinical importance of that? So this progression allows for opportunities for early intervention. Stage A, this classification of ACC AHA, involves patient at risk for heart failure, for example, hypertension, diabetes, but without structural changes. Stage B has structural heart disease, for example, left ventricular hypertrophy, prior myocardial infarction, MI, but no symptoms for a moment. Identifying and aggressively managing risk factors in stage A and B can delay progression to symptomatic CHF, chronic heart failure, i.e. stages C and D. Okay? So this pre-heart failure concept is critical for primary and secondary prevention as well. Okay? Now concerning ejection fraction, my beloveds. Doesn't tell whole story. Heart failure commonly categorized by left ventricle ejection fraction. However, about 50%, half, of chronic heart failure patients have preserved ejection fraction, meaning their left ventricle ejection fraction is more than 50. It's so-called diastolic dysfunction. While the other have almost half reduced ejection fraction. Left ventricle ejection fraction less than 40. Now we've got 40%, of course. This is a systolic dysfunction. And also we've got a third category, mild reduced ejection fraction, as ejection fraction means 40 up to 50%. So distinction is vital for management. While heart failure with reduced ejection fraction, has well-established therapies. We know that. Diuretics, blockers, AC inhibitors, and so on. Heart failure with preserved ejection fraction has fewer universally effective treatments, though SGLT2I class medications, fashion medications, are showing promise. I don't know. Recognizing heart failure with preserved ejection fraction emphasizes the importance of diastolic dysfunction and often requires managing comorbidities like hypertension, diabetes, and obesity, but don't forget that managing lifestyle changes is the primordial in both cases. You start with managing lifestyle. This is of paramount importance. We will talk about that. Now about neurohormonal activation. Is a double-edged sword. This neurohormonal activation is response to decreased cardiac output. The body activates compensatory mechanisms like the renin-angiotensin aldosterone system, RAAS, abbreviation RAAS, and the sympathetic nervous system, SNS. This initially helped maintain blood pressure and perfusion, but then begin catecholamine intoxication. catecholamine intoxication. Chronically, this neurohormonal activation becomes maladaptive, leading to vasoconstriction, fluid retention, and cardiac remodeling, hypertrophy, fibrosis. So our most effective therapies are Zartans, AC inhibitors, beta blockers, MRA, directly target and mitigate these harmful neurohormonal pathways, improving symptoms and survival, especially beta blockers. But again, don't forget about, yes, regular physical activity. This is the core of the problem. Now about natriuretic peptides. So brain natriuretic peptides, BNP, and N-terminal pro-BNP are hormones released from cardiac ventricles, my beloveds, in response to stretch and wall stress. Their levels, of course, are elevated in chronic heart failure. They are invaluable for diagnosis, especially differentiating chronic heart failure from non-cardiac causes or dyspnea, assessing severity, actually guiding therapy, or, for example, optimizing diuretic doses. And prognosis, of course. Persistently high level despite treatment indicate inadequate disease control. They also reflect the underlying pathophysiology as ARNI, like ARNI, like sacubitril, valsartan, work by inhibiting neprilysin, an enzyme, neprilysin, that degrades natriuretic peptides, thereby increasing their beneficial vasodilatory and natriuretic effects, they say. And don't forget about iron deficiency. It's a common and treatable comorbidity, anemia. Yeah. Even in the absence of anemia, iron deficiency is common in chronic heart failure, patients affecting to 50% regardless of left ventricle ejection fraction. So iron is a crucial for cerebral energy production. Iron deficiency in chronic heart failure is associated with worse symptoms, reduced exercise capacity, poorer quality of life, and increased hospitalization and mortality. So they use intravenous iron supplementation. For example, ferric carboxymaltose has been shown to improve functional capacity, quality of life, and reduce hospitalizations. But don't forget about, once again, lifestyle, dietary management, eating good quality meat, of course. So what else? This highlights the importance of routine iron status assessment for chronic heart failure. About sleep apnea, both obstructive and central. It's incredibly common in chronic heart failure, affecting 70% of patients. Central sleep apnea, characterized by chain-stocks breathing pattern, in particularly associated with heart failure with reduced ejection fraction, so snoring. What is clinical importance of that? The sleep apnea exacerbates chronic heart failure by causing intermittent hypoxemia, sympathetic activation, increased intrathoracic pressure, and fluid shifts. While treating obstructive sleep apnea, for example, with continuous positive airway pressure, so famous CPAP, can improve symptoms, the benefit of treating CSA, central sleep apnea, on chronic heart failure outcomes is less clear. So nevertheless, screening and addressing sleep-disordered breathing is an important aspect of holistic chronic heart failure management. Renal dysfunction. Renal dysfunction is a vicious cycle, of course. Cardiorenal Syndrome describes the bidirectional relationship where cardiac dysfunction leads to renal dysfunction and vice versa. Impaired renal perfusion due to chronic heart failure can lead to worsening kidney function, which in turn impairs fluid balance, my beloveds, and drug elimination, making chronic heart failure hard hit harder to manage. Much harder to manage. Much more harder. So the interplay necessitates careful monitoring of renal function. No, for example, serum creatinine, estimated glomerular filtration rate, eGFR, when initiating or titrating medications like Zartans, diuretics, and so on, as many can affect kidney function. So finding the right balance to manage fluid status without compromising renal perfusion or causing electrolyte imbalances is a constant challenge, a very hard challenge, serious challenge. About arrhythmia, of course, it's atrial fibrillation. It's a frequent and detrimental partner of problem of chronic heart failure. Atrial fibrillation is the most common sustained arrhythmia in chronic heart failure, affecting 30 to up to 50% of patients. The presence of one condition increases the risk and severity and complications of the other. Atrial fibrillation significantly worsens chronic heart failure symptoms and outcomes by causing loss of atrial kick, rapid ventricular rates leading to tachycardia-induced cardiomyopathy, and increased risk of thromboembolic events. Stroke. Management involves rate and or rhythm control strategies. Of course, anticoagulation in rate control and rhythm control to prevent stroke, and often necessitates shared decision-making regarding the optimal approach, of course. Now about the classics, once again, you will be asked about that. It's a NYHA classification, the symptom barometer. The New York Heart Association functional classification, established in 28. No, I don't know actually. Very old, very good classification, remains a cornerstone of chronic heart failure assessment, categorizing patients based on their level of symptom limitation during physical activity. So class 1, no limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation or dyspnea. This is a class 1. Class 2, slight limitation of physical activity, comfortable at rest. Ordinary physical activity results in fatigue, palpitation or dyspnea. Actually, dyspnea is a primary complaint, principal complaint of heart failure. Next, class 3, marked limitation of physical activity, comfortable at rest. Ordinary comfortable at rest, less than ordinary activity causes fatigue, palpitations, and or dyspnea. And finally, class 4, the worst one, unable to carry on any physical activity without discomfort, symptoms of heart failure at rest. If any physical activity is undertaken, discomfort is increased. Okay, so NYHA classifications guide its prognosis and therapeutic decisions. No, NYHA means New York Heart Association. NYHA. It's a quick, practical tool for assessing disease severity and tracking response to treatment, i.e. improvement in NYHA class is a key therapeutic goal indicating better quality of life and often correlating with improved outcomes. It's also often used in conjunction with stages of ACC, AHA that I mentioned above from the beginning. Okay? And once again, don't forget about regular physical activity, because regular physical activity is of paramount importance. While seemingly counterintuitive for someone, for a weakened heart, regular supervised physical activity, cardiac rehabilitation, is a cornerstone of chronic heart failure management. Not just an adjunct, my beloveds. It's a cornerstone. Clinical importance. Exercise training in chronic heart failure is safe, improves exercise capacity, reduces symptoms, enhances quality of life, and significantly decrease hospitalizations as well as mortality and morbidity ratio. It directly counteracts deconditioning, improves endothelial function, and reduces sympathetic tone. Huh? Don't like athlete's art, yeah. Prescribing tailored exercise regimens is a vital component of medical care, directly impacting patient functional status and longevity. And about pillars of medical therapy. Over the past few decades, medical therapy for heart failure, reduced ejection fraction, has undergone so-called pharmacological revolution with drugs specifically targeting neurohormonal pathways, transforming prognosis, as they say. So the current guideline-directed medical therapy, GDMT, guideline-directed medical therapy, optimal therapy for heart failure, reduced ejection fraction, includes a quadruple therapy approach: angiotensin-resin neoprelizin inhibitors, ARNI, sacubitril valsartan, or angiotensin converting enzyme inhibitors, AC, lisinopril, for example, angiotensin receptor blockers, valsartan. Don't forget about our king beta blockers, carvedilol, metoprolol, mineralocorticoid receptor antagonist MRAs like spironolactone, alprazolam, and finally sodium glucose cotransporter 2 inhibitors, for example dapagliflozin, empagliflozin, if I pronounce correctly. These medications are often used in combination and titrated to maximally tolerated doses, have been proven to reduce mortality, reduce hospitalizations, and improve quality of life. Here we believe medical literature. Diuretics, furosemide are also crucial, of course. Don't forget about the diuretics for symptom relief from congestion, but do not directly impact long-term mortality. We know that. And finally, utopia. Utopia is a heart transplantation for a very select group of patients with end-stage refractory chronic heart failure, typically NYHA class 4, ACC-HAA stage D, who remain symptomatic despite optimal GDMT. Heart transplantation offers the best long-term survival and quality of life. Utopia, because it's not for everyone, unfortunately. Heart transplantation is a complex procedure with strict selection criteria considering patient age, comorbidities, psychological factors, and the severity of illness. It involves lifelong immunosuppression to prevent rejection, but it can dramatically transform the life of very carefully selected individuals. Understanding the indications, my beloveds, contraindications, and post-transplant care is crucial for clinicians managing advanced heart failure, chronic heart failure. For patients not suitable for transplant, mechanical circulatory support disease, for example, LVAD, left ventricular assist device, may serve as a bridge to transplant or as a destination therapy. So that's all, my beloveds. I suppose I clarified all questions that were misunderstood or confused you during these previous board exams. Thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my private Dr. Y Telegram channel. How to find my Telegram channel? No, first you have to have this on your phones. So Telegram, you tap in searching mode in Telegram, Dr. Y, WHY, without question mark. Dr. Y, it's me. You click start and you choose your plan for months or for a year, up to you. It's not costly at all. Stay blessed.